MCTAC and CTAC teams. And we're really excited to be offering the 5th and final webinar of the SPA series on crisis intervention. So this has been the culmination of a weekly series, and hopefully that folks have had a chance to be a part of other of the presentations. Today, Barry Kinlan and Lisa Fiato are going to be talking us through the Crisis Intervention Service and some of the detail and nuance around that. So thank you to Barry and Lisa for joining us today and spending some time talking folks through it. In terms of just quick housekeeping logistics, just on the off chance that this is your first time coming to a CTAC, MCTAC webinar, or you need a quick refresher, so we encourage folks to really do please chat in your questions throughout the presentation as they come up. You do not have to hold them until the end by any means. Slides are posted at ctacny.org. And they're currently posted, and a recording will be available soon. It usually takes about a day or so, but definitely within a week of the presentation. I just wanted to highlight for folks, if you didn't see the announcement about the new CTAC MCTAC website, that's ctacny.org. It combines all of the content and presentations from both of the sides, so it'll save us from having to explain the difference between the two, which is great for everyone. But if you go to ctacny.org, or you could still navigate there through mctac.org. It'll just redirect to this page. You would go to offerings and system transformation, and there's an entire bucket of work for the children's system transformation there, which includes everything from the SPA webinar series to readiness assessment findings for child-serving organizations, some of the in-person and web-based presentations and content that we've done earlier this year as well. So if you haven't yet, please do check that out. If you have any questions or difficulties, please don't hesitate to get in touch. Just a reminder that questions not addressed today will be reviewed and incorporated into future training and resources, including a Q&A document and incorporated into the FAQ tool, which is also at the CTAC and MCTAC website. And then just as a friendly reminder, the information and timelines are current as of the date of the presentation. And as we all know, sometimes timelines and some of the nuance can shift. But to the best of our knowledge and ability, this is a great picture of crisis intervention and this children's system transformation. So the quick goals for today is to review the key information around crisis intervention. This is pulled from the draft SPA manual. So if you haven't had a chance to take a look at that, we strongly recommend you do so. And while we're going through, the content has been slightly translated and modified in places just to help with understanding and for learning purposes. And so we'll be adding context and clarity along the way, as well as a fantastic example at the end of what this service might look like to kind of bring it to life. And then we're also hoping to generate and answer questions. So again, please do chat those in. It's really helpful and beneficial for us to see what areas folks are interested in or might need more information around. And then again, we'll just quickly be hearing a children's system transformation and SPA refresher and update. This is very similar content to what's been presented the last few weeks, but with a new presenter, so it should be extra fresh and interesting for everyone. There'll be a crisis intervention walkthrough. We'll come back on our end, and just really quickly talk about any upcoming training and resources, and then we'll leave plenty of time at the end for Q&A. So with that, I will turn things over to Barry and Lisa. Take it away.
Thank you, Dan. Welcome today to our Crisis Intervention webinar. So as Dan said, we're going to go through a quick overview and refresher of the Children's State Plan Amendment. Okay, so what's ahead for New York's children's system? First, coming in December of 2016 is the Children's Health Homes, which will go active statewide, and we've provided here a link to the Children's Health Home New York State Department of Health website. We encourage you to go to that website if you need any more information on this. The new state plan services, which we'll be talking about today, will go statewide January 1st of 2017. The behavioral health and SPA services will both transition to managed care. Now, this also includes children in the care of voluntary foster care agencies, and this will occur July 1st of 2017 for New York City, Long Island, and Westchester. Following that, in January 1st of 2018, will be the rest of states. And those timelines are also the same for the Children's Home and Community-Based Services, referred throughout this webinar as HCBS, and they will be transitioning to managed care, like I just said, for New York City, Long Island, and Westchester in July 1st of 2017, followed by January 1st, 2018 for the rest of the state. Okay, so the Children's Medicaid State Plan Amendment Update. The SPA manual, a draft of that, was released on March 9th, 2016, and it can be found on the MCTAC website, which we will provide in this webinar slide. The 6 new services are as follows: crisis intervention, which will be our focus today, and then the 5 other services are other licensed practitioner, community psychiatric supports and treatment, psychosocial rehabilitation, family peer support services, youth peer support, and training services. Now, the SPA designation and application, which you may have heard about, is in the final review stage, and we hope to have more information on that forthcoming. And as we mentioned, I believe, on a previous webinar, the SPA rates will be made public as soon as we are able to. Okay, just let's go over the SPA goals here. The main goals of these additional services in the state Medicaid plan are to identify needs early on in a child's life, to maintain the child at home with supports and services, as well as maintain the child in the community. We also want to prevent the need for long-term and or more expensive services, as well as increase the delivery of services following trauma-informed care principles. Okay, the SPA Provider Manual Organization, as we mentioned, was released back in March, and it's structured in, as you see the bullets in front of you here. First, we go through the service components, followed by the allowable service modalities and the allowable settings. And then we go into admission and discharge criteria, which is essentially medical necessity, followed by limits and exclusions. And then we close the manual organization for each service up through the practitioner, agency, and supervisor qualifications, mentioning training requirements and recommendations, and then recommended staffing ratio, as well as caseload size. And this manual is available at the ctacny.org website, and you're going to want to look for that under the Tools section. Okay, so some key points we want to hit on about these Medicaid state plan services. These services are going to be available to all Medicaid-eligible children under the age of 21 who meet the medical necessity criteria. The services will be delivered in a culturally competent manner and be trauma-informed. They will allow interventions to be delivered in a natural, community-based setting where children and their families live and bolster lower-intensity services to prevent the need for more restrictive settings and higher-intensity services. As well, these fall under the early periodic screening, diagnosis, and treatment benefit. It's going to be referred to as EPSDT from here on out. And a few more key points that we'd like to hit on before we get into the crisis intervention details. So these new benefits are going to be standalone services. They're not programs. The services are going to be provided to children and youth and must include communication and coordination with the family, caregiver, and or legal guardian. Coordination with other child-serving systems should also occur to achieve treatment goals. When the SPARS services are launched, they will initially be billed under Medicaid fee-for-service until transition to Medicaid managed care. And then finally, once designated for SPA services, providers can begin the contracting process with the Medicaid managed care plans. We hope for this to start in January of 2017. And further training on contracting is planned. So just be aware that we're going to come out with more detail on that. And I just want to close with a little more information on medical necessity. So medical necessity includes any treatment that corrects or ameliorates conditions found through an EPSDT screen or addresses the prevention, diagnosis, and treatment of health impairments. Also, the ability to achieve age-appropriate growth and development is important, and the ability to attain, maintain, or regain functional capacity. Now, each of the 6 state plan services that we are talking about today and have previously talked about will have criteria for admission, continued stay, and discharge. And we'll hand it off to my colleague from the Health Department, Lisa Fiato.
Thank you, Barry. Okay, so today we are talking about the SPA service of crisis intervention. Crisis intervention services are provided to children and youth under the age of 21, and his or her family caregiver who is experiencing a psychiatric or substance use behavioral health crisis and are designated to interrupt or ameliorate the crisis experience, include an assessment that is culturally and linguistically sensitive, result in immediate crisis resolution and de-escalation, and develop a crisis plan. Defining what the family means. The family is the primary caregiving unit, inclusive of a wide diversity of these units in our culture. Family is a birth, foster, adoptive, or self-created unit of people residing together with a significant attachment to the individual, consisting of adults and/or child or children, with the adults performing duties of parenthood, caregiving for the child or children, even if the individual is living outside of the home. Goals of crisis intervention. The goals are to provide the following when a child or youth is having a behavioral health crisis: to provide engagement, symptom reduction, stabilization, restore individuals to a previous level of functioning, or develop coping mechanisms to minimize, prevent future crises. Avoid inpatient admissions when possible and appropriate. Some of the service components involved with crisis intervention will be assessment of risk, mental status, and medical stability, crisis resolution and debriefing, development of a crisis plan, consultation with physician or other licensed practitioner of the healing arts, and follow-up within 24 hours. Services should follow any already established crisis plan to the extent possible. If there is not an established crisis plan, the crisis intervention team is expected to develop a crisis plan, which should include components of addressing the safety with the child and the family and caregiver. For the assessment, the need to assess. You have to assess the risk, safety, mental status, medical stability, need for further evaluation, and the need for other health or behavioral health services. The purpose of the assessment is to determine the level of safety, risk, and plan for the next level of service. Crisis resolution and debriefing. Within the 72-hour time frame of a crisis, de-escalation techniques are utilized to help calm the child. Information is gathered from the child, the family, and/or other collateral supports on what may have triggered the crisis. Information is gathered on the child's history. Review of medication occurs if that's appropriate. A crisis plan is developed with the child and the family, and a warm handoff to providers of needed services. Debriefing with the child, the family, the caregiver, and the treatment providers. The 72-hour time frame. Episodes are defined as starting with the initial face-to-face contact with the child. Child's chart must reflect the resolution of a crisis within the 72-hour period. If the child has a new crisis within the 72-hour time frame, it is considered part of that original episode, and a new episode is not billable. Once current crisis episode and follow-up exceed the 72-hour time frame, considering a new crisis intervention episode, or will be transferred to a longer-term service for rehabilitation, skill building, such as CPST. Crisis planning. A crisis plan should be written in appropriate, readable level for the child, when appropriate, preferred language addressing cultural issues whenever possible, and the safety plan should address the following: immediate circumstances, prevention of future crises, signing of appropriate consents for release for follow-up referrals to services, and/or collaboration with existing providers of recipients. Consultation and follow-up. Crisis services include consultation with a physician or other licensed practitioner to assist the child's specific crisis and plan for the future services. Follow-up with the child and family caregiver within 24 hours of initial contact or response. Inform the primary care, behavioral health treatment provider, or care coordinator of the development of a crisis plan. Entity referred to conducts the evaluation and assessment for additional longer-term services. Exclusions. The following activities are excluded: financial management, supportive housing, supportive employment services, basic skill acquisition services that are habilitative in nature. Services may not be primarily educational, vocational, recreational, or custodial. Services do not include services, supplies, or procedures performed in a non-conventional setting, such as resorts, spas, therapeutic programs, and camps. Responsivity, 24/7 availability, weekday, weekend, and evening. Capacity to respond in 1 hour of the call. Callers connected to crisis specialists who triage the call. This may include an option for transferal to 911 if immediate danger, and crisis intervention team dispatched in conjunction with 911 should be needed. Approach. All engagement and other work with the child, family, and caregiver, or other collateral sources, such as the school personnel, should be culturally and linguistically sensitive, child-centered, family-focused, and trauma-informed. Allowable modalities. Individual face-to-face intervention with the child and their caregiver and the collateral. Expected follow-up in person or by phone. The settings. Service delivery can occur in a variety of settings, including emergency room or behavioral health clinic setting, other community locations where the child lives, attends school, works, engages in services, like a provider office site, and/or socializes. Eligibility. For children and youth experiencing a serious acute psychological or emotional change, results in a marked increase in personal distress, exceeds the abilities and the resources of those involved, i.e. or e.g. collateral, provider, community member, to effectively resolve it. Determination of crisis is defined by a behavioral health professional. Assessment of risk, mental status, and medical stability to determine if crisis response services are required. The child or youth may be represented by a family member or collateral contact who knows the child or youth's capabilities and functioning. Medical necessity, recommendation for the service. Services can be recommended by the following licensed practitioner of the healing arts: a psychiatrist, a physician, a licensed psychoanalyst, a registered professional nurse, a nurse practitioner, a clinical nurse specialist, a licensed clinical social worker, a licensed marriage and family therapist, a licensed mental health counselor, and a licensed psychologist. Professionals may or may not be part of the crisis intervention team. Medical necessity for purposes of admission. All activities must occur within the context of a potential or actual behavioral health crisis. Desired outcomes is to divert the emergency room visit and or the inpatient admission when appropriate. The family and caregiver may request assistance with a crisis to prevent the licensed practitioner of the healing arts, LPHA, still needs to recommend the service in this case, though. Please keep that in mind. Of out-of-home placement, violence, maintain safety of the child or others in the home, address other conflicts as needed for the emotional health, development, and safety of the child. Medical necessity for substance abuse. Screening for substance use disorder should be addressed in an integrated fashion. Crisis services should not be denied based on the use of alcohol and or drugs. The crisis team members should be trained on screening for substance use disorders. In discharge, the child demonstrates engagement, symptom reduction, stabilization, and restoration or developing the coping mechanisms to pre-crisis level of functioning. The child, youth, and family has been involved in the discharge process. Expectations are that within the 24-hour follow-up should be facilitated, a warm handoff to the needed services, documentation must reflect resolution of the crisis, which marks the end of the episode upon warm handoff to the needed services. Include a referral for chemical dependency services if indicated. Agency qualifications. Crisis intervention practitioners must work within an agencies that have a current license to provide crisis and or crisis treatment services. Any child-serving agency or agency with children's behavioral health and health experience that is licensed, certified, designated, and or approved by either DOH, OASIS, OCFS, or OMH to provide crisis and or crisis team services. Your multidisciplinary team. Services should be provided by a multidisciplinary team, including at least 2 licensed practitioners, a licensed clinical social worker or licensed master social worker, a licensed mental health counselor, a licensed psychologist, a licensed marriage and family therapist, a nurse practitioner with experience and background with treating mental health and or substance use disorders, or 1 practitioner from the above list and 1 practitioner from the following: a credentialed alcohol and substance abuse counselor, a certified recovery peer advocate and family, credentialed family peer advocate, a credentialed rehabilitation counselor, or registered professional nurse. Some limitations of peer services. Peers may not provide the following service components: the assessment of risk, mental status, and medical stability, service planning, care coordination, consultation with the licensed practitioner, referral and linkage to other services to avoid more restrictive levels of treatment, and documented follow-up within 24 hours of the initial contact. 1 member of the team must be a behavioral health professional and have experience with crisis intervention service delivery. If determined only 1 team member is needed to respond, that person must be the behavioral health professional with crisis service experience. A peer support specialist may not respond alone. Supervisor qualifications. A licensed clinical social worker, a licensed psychologist, or physician. They must practice within the state health practice laws and ensure that providers are supervised as required. For example, if a psychiatric nurse practitioner is on the team with fewer than 3,600 hours of experience, a psychiatrist must be on the team and supervise him or her. Supervisors must also be aware of trauma-informed care, cultural needs of the population of focus, and how to train staff regarding these issues. Some training requirements we have. Peer support providers must have a certification as one of the following: an OMH-established family peer advocate, an OASIS-established certified recovery peer advocate family. There's links below each one of those to obtain some additional information. All practitioners delivering crisis intervention services must have training provided in the following areas prior to delivery of the crisis service. They must have first aid, CPR, mandated reporting, crisis de-escalation, resolution and debriefing, suicide prevention, and crisis plan development. Additional trainings that are recommended: domestic violence, signs and intervention, linkage facilitation, bridging and transition support, medications, intended effects, interactions, and side effects, motivational interviewing, personal safety in the community, substance use, signs and symptoms, and some below are some training resources with some links that you can obtain some additional information. A crisis intervention example. Okay, we have Boris. He's a 12-year-old, and he has been having a very hard time at school. He receives clinic services, and in the last week, his mom, Anna, has received 3 calls from the school about incidents that have occurred. Today after lunch, Boris became aggressive towards a classmate. The school calls Anna and says they plan to call 911. Since Boris is in treatment, Anna suggests they first coordinate with his ongoing therapist, who contacts Anna with the crisis intervention team. The crisis team arrives at the school where Boris has de-escalated. The LCSW conducts a safety and risk assessment. Upon determining Boris is not an immediate risk to himself or others, the crisis team that includes a family peer and support service professional meet with Boris and Anna, as well as the school personnel, to develop a safety plan. The crisis team then transitions and reconnects Boris back to his ongoing clinic service provider for follow-up and ongoing care. To be finalized and announced, the provider designation criteria and process, the SPA service documentation requirements, utilization management process, the crisis intervention specifics, billing methodology and coding structure, language further defining medical necessity criteria, and additional limitations. Once these are finalized, these will be incorporated into the SPA provider manual and will be shared widely.
Hey, thanks so very much, Lisa and Barry.
Sorry, I was going to say I'm handing it back over to you, Dan.
You're on a roll. If you'd like to keep going, you're welcome to.
I am on a roll here. Nope, you can take it over. It's okay, Dan.
All right, very good. Caitlin, if you wouldn't mind passing the ball back over, and I'll click through as quickly as I can the remainder of the slides for today. So thanks again to Barry and Lisa. That was really terrific and a really helpful example. Thanks to everyone for sending the questions in. We've been getting a good assortment of questions so far, and we're leaving plenty of time at the end to be sure to get to as many of those as we can. So as you can see on the screen now, the SPA training series is now concluding, but don't worry, there's going to be more coming down the line in terms of the Children's State Plan Amendment. And TA and information on everything from the designation process when that's available, all the way through implementation and billing and authorization and all of that good stuff. So rest assured that'll be happening soon. And then just wanted to plug the state-led training on the CANs. And I believe that the capacity for both the New York City and Rochester trainings, which are coming up in August, they're at capacity, but there are wait lists available. So you can join the wait list and for those events, it's very possible that space might open up, so I would encourage folks to do that. As we mentioned, so the work on SPA and the training and technical assistance around this area and these services doesn't end here. So again, we're wrapping up with the high-level service-by-service overviews, and then we'll be talking about the designation process when available, billing rules. Barry mentioned earlier that information on rates will be available in the coming over the next few months. So then with October, November, December, so we'll be working with the state and the kids work group closely over the next couple of weeks to really refine and define what this looks like in terms of the number of trainings and where and how many. So stay tuned for exciting updates on that front. But we know how busy folks are, so please just remember that we understand and know how much everyone has going on, so we appreciate you taking the time to join us for these trainings, and we'll do everything in our power to make sure that the layout and approach to TA and training is as helpful for you and also time effective for you as possible. Again, you've probably seen this slide before, but if you have questions about the transition to managed care or what was discussed today in terms of the state plan amendment, here are some great places to turn to for more information in your questions. So the OMH Managed Care Mailbox for DOH, for Health Homes for Children, OCFS and OASAS are all here. There's also a link at the bottom of this slide for information on more generally about the Children's Managed Care Design, which is a fantastic resource. And we would be remiss not to also mention mctac.info at nyu.edu as an option for folks to send their questions. So logistical questions, of course, get a quick turnaround, usually no more than 1 business day. Those are for things, I'm having trouble accessing my account or registering for an event, or can you point me in the right direction for this? But, as some questions come through that are a little bit longer and more complex with ongoing policy discussions, those can take a little bit longer, but we do receive and respond to all questions that come through. I believe we're up to something like 4,000 questions since the inception of MCTAC back in September of 2014, which seems like yesterday, but it also seems like 10 years ago. So thanks so much for your interest and your questions. We really appreciate the opportunity to be working with everyone on the system transformation. So with that, we'll do one more plug for folks to please send in any questions that have come to mind during the webinar. On our end, just so Lisa and Barry and the folks with them up in Albany are aware, we'll be copying and pasting the current list into an email and sending those over to you now, so you have those all in one place. And we'll get started with Q&A in just a second if folks can bear with us as we get organized. So thanks again, everyone, and please send us your questions, and we'll get started with the Q&A portion of the presentation in just a minute.
Hello, everyone. This is Tiffany Battles from OMH. I think we're going to start answering. We have some questions in here. One of the questions that we have up is, does the person triaging and making the recommendation for crisis intervention services have to be a licensed professional of the healing arts? That answer is yes, that we expect that the individuals that will be triaging calls are licensed professionals, some of which we listed previously when we were discussing crisis intervention, and that these licensed professionals would need to make that recommendation that a crisis intervention service is needed. So that answer would be yes.
And this is Lisa Clark, and I'm at OMH also, and we're just going to be forthcoming with the fact that a lot of the answers to some of this is still in development. So I think we, need to make sure folks know that, and we'll answer these to the best of our current ability. So we have, when these services transition to managed care, can agencies without Article 28 or 31 licenses, can they still provide these services and bill managed care? So there's not a requirement in here. So for those of you not in the know, Article 28 or Article 31, those are clinic providers, but there's nothing in here stating that you have to be a clinic provider in order to provide these services.
Thanks, Lisa. That's really helpful on that front. And we were talking about that question on our end as well, and would just also chime in that the providing and billing isn't determined by being in Article 28 or 31, but being licensed to provide Medicaid services. So is that understanding correct?
Well, it will be part of the designation process, who's going to be designated to provide these crisis intervention services. So,
Great.
You know, agencies that are already doing services will certainly be ones that are more likely to be designated. There's no, again, I'll repeat, there's no requirement that you have to have a clinic license in order to do these. Here's a question: if services can be completed in the emergency room setting, how will that affect billing? Would this be considered double billing or duplication of services? I'm going to say at this point in time, we can't answer that question. Obviously, the goal of any type of crisis intervention and mobile services is to get to people and hopefully de-escalate the situation in the crisis prior to anyone being in the emergency room. But the nitty-gritty of the details on billing questions like that will still be, once we have those answers, we'll share them when we get further down the road.
We have another question of, in terms of medical necessity, does the potential need for this service need to be identified ahead of the crisis by the licensed practitioner of the healing arts, working with the youth, or can the medical necessity be established by the crisis intervention team that are the ones responding upon receiving a crisis call? So again, lots of discussion still going on, but in thinking of our triaging and that it could potentially be licensed professionals who are answering the phone and possibly the same professionals who are going out to deliver the crisis intervention service, I think this is a great question, and it could possibly go either way, that they may decide the need for that service by phone, or it could be that the crisis intervention team is responding to a call, and then there may be a supervisor like an LCSW who may be staffing that triaging line that then the crisis team may check in with to see whether the potential crisis is there. So again, there's more discussion on this, but good question.
And I'm just going to say, in keeping it real, we all know, anyone who works with children, you're not going to identify ahead of time that there's going to be a crisis. They're going to happen, and they're going to happen in the moment. And I know that the example we gave kind of had a couple phone calls made, but in the real world, there's a crisis, and you want someone to get there and get there quickly. So you would be contacting these folks with the mobile teams or the triaging entity. Again, there's some of these components and decisions are part of a larger work group and things that need to be designed, and we'll work through those details, but it's not, we don't expect you to know ahead of time and plan for that. Are there plans to grandfather in MSWs who have years of experience to provide care and to supervise? I'm going to say at this point there's not a plan for grandfathering. You know, we'll make note of that comment and take it into consideration. How do providers determine the Medicaid eligibility status of those in crisis? Can crisis intervention take place without consent if consent is in place by the end of the 72-hour period? Okay, so for the first thing, determine the Medicaid eligibility status of those in crisis. I mean, obviously some of these questions are tricky, and it all has to do with the rapport that you have with the individual. Some of these folks will be, you know, known entities who have had repeated crises. There's a place and a time. If someone calls and they're in immediate danger, you're not going to sit there and ask for their, you know, their Medicaid ID number in order to determine, you know, what plan they're affiliated with. We would expect you to respond to the crisis at hand, and then after the fact try to gather the appropriate, you know, insurance information in order for you to bill. And the second part of that question, can crisis intervention take place without consent if consent is in place by the end of the 72-hour period? I'm not sure exactly what we're talking about, but if a person is a danger to themselves or others, then no consent needs to be given for a response, and if, you know, the police need to accompany and also provide, I mean, there's not a consent period to respond.
This is Angela Keller from OMH, and certainly in most cases with children, probably the family member or guardian is the one that's going to make the call, that their ability to respond to the crisis has now reached a point that it's beyond their personal resources, and they need help. So by nature of them making the call, they've essentially consented to whatever comes next. So one of the questions, if an evidence-based practice provides crisis intervention services by an unlicensed professional as part of that model, what would we bill as? Just as a reminder, in one of the previous webinars, evidence-based practices, if a provider is designated, that is paid under CPST for unlicensed professional, so it would not be billed under this service because it would be a component of that evidence-based practice model. But again, those would be things that would be detailed in the billing manual that's yet to be developed.
Okay, and we're just waiting for some new questions to come in here. We're trying to crosswalk what we've already covered.
So there's a timeline question. Sorry, go ahead.
I'm sorry, Dan. This is Tiffany Battles again. We have a question on responsivity. That 1 hour response to a call, is that face-to-face or phone call? That would be face-to-face. We do realize that, you know, geographically and even capacity-wise, that providers, this would be something that they would need to really build up to and have the resources to provide. But again, this is, when we say 1 hour responsivity, we really mean that face-to-face interaction that you have with that child or youth.
And since the expectation is that there's 24/7 coverage, that the answer of the phone call is always there, continuously 24/7, and then the face-to-face is a 1 hour if it's necessary for a team to go out.
Great. And we noticed the timeline question come in the background, so that's a great chance just to take a pause and look back to the What's Ahead for New York State's Children's System slide. So again, just to clarify, so the question was talking about when state plan services go live, and then HCBS and SPA and rest of state in New York. So there's a lot of acronyms and there's a lot going on. So let's just take one more quick look back to this. So health homes are currently scheduled to go live on December 1st, and that's statewide. The state plan services, so these SPA services that we're talking through, including crisis intervention, is scheduled to go live statewide on January 1st, 2017. This is before the managed care or HCBS implementation, which happens later in 2017, in July for New York City, Long Island, Westchester, and then rest of state, January 1, 2018. So for folks who are wondering, we've gotten this question quite a bit, that SPA services would be billed fee-for-service until the managed care transition occurred, when they would be folded into managed care.
Thanks, Dan. We're just looking at this questions list again. There's a question on, will crisis intervention services be given to people in the OPWDD population? The answer to that is only if the child or youth is experiencing a behavioral health related crisis.
Can you please repeat what the modalities were? So that was face-to-face, in person, or by phone. I'm not sure if you were looking for more on that, but crisis services can be provided by phone. They're reimbursable by phone. So if you're doing triaging and you're able to de-escalate the crisis by phone, then that will be a reimbursable service.
Okay, we have a question about what is the longest amount of time a professional can stay involved with a family in crisis. So as we mentioned in the PowerPoint, we have the 72-hour time frame where we really outlined all the expectations that would occur within that 72-hour period. If a crisis, let's say the child goes home with this crisis plan, has another crisis within that 72-hour period, it would be considered part of that overall crisis, so a new crisis service cannot be billed. But if it exceeds that 72-hour time frame, then it can be billed as a new crisis. So the 72-hour time frame is the longest amount of time, and if it exceeds that, then it would need to be a new billable service.
And the expectation would be is as a crisis encounter is completed, if you will, that there are needs and services that are likely to be identified through that crisis intervention service delivery. And so we would hope that that team would be making appropriate referrals in the community, such as community psychiatric supports and treatment, where more time could be spent over a course of weeks to work with that child and family about identifying triggers potentially that could bring on another crisis, what are some skills that they need to work on, how might they set up their situation and to avoid those in the future. So that's where the longer term support to identify maybe what precipitated that crisis so that it doesn't happen again or potentially to the degree that it did.
There's a question, is crisis intervention limited to youth who do not have a current mental health provider, or can youth have mental health services in place and still have access to these services? Certainly, even if you have mental health services in place, you would be able to access these services.
Assuming you're enrolled in Medicaid.
Does having crisis intervention identified in a child's IEP meet medical necessity criteria? That's outside. There's no IEP required in this. They're presenting as,
it's an emergency service.
Right. There's a question on it takes an hour or more to travel one way to many clients' homes. If we are billing for 1 hour of crisis, shouldn't billing include travel time? I'm going to just all of the questions that pertain to the specific nuances and details, nitty-gritty of the billing stuff, it's still to be determined, so we cannot answer those questions at this time.
Well, one question did come in as crisis respite a billable service. Crisis respite can be addressed through the home and community-based services that will be available under the 1115 later in 2017 and then in 18. So remember, respite is a service in that array for those that are eligible for level of care or level of need, and that includes both planned respite and crisis respite. So crisis respite would not fall under this crisis intervention service that we're talking about.
We've also gotten questions that don't pertain to this particular topic that are general other questions. You can send those questions to...
It'll come in as part of the Q&A, and we'll direct those questions where they need to go. So there's health home questions that are being sent in, cans, fans, and we'll get those to the correct people.
There's a question here on expected follow-up, whether it's in person or by call. Is that for after the crisis intervention? Yes, it is. If so, the time frame we state in our manual that we expect that within 24 hours of the crisis, and this is really to highlight that connection to follow-up services for the child or youth. We mentioned CPSP, for example. As far as the 1-hour response time, this is the response time that regards the actual going out to respond to the crisis. So when we're talking about follow-up, we're talking about after that crisis intervention has happened. We have a question on, can crisis respite be recommended as part of the crisis plan? Absolutely. That we would hope that services such as crisis respite be a follow-up service if that is appropriate for the child or youth.
And if the child is HCBS eligible.
Great, so it looks like the flow of questions has slowed down, so we've got a couple minutes left if anybody else has anything else to add. Otherwise, we really appreciate everyone attending, and we'll be pulling this together into a series-long Q&A document to get back out into the world. So just maybe give it one more minute and see if there's anything else.
I think we've pretty much answered the questions that we can at this point in time. I know that some of you have submitted some questions that we have not answered because we are not able to provide you with answers at this time, but the CTAC folks will take those down to MCTAC folks, and we'll do our best to get back to you.
And to quote Lisa Clark from earlier in the presentation, keeping it real. So we appreciate that, Lisa. All right. Well, thanks everyone for joining us for the crisis intervention presentation today. To Barry and Lisa in particular for the presentation, and to all the folks up in Albany for your help and work on the Q&A. So we're going to sign off, and we'll be posting the recording of this in the next day or so. So stay tuned for more information on the SPA TA training technical assistance front soon. Thanks so much, everyone.